Good morning, everyone. I'm going to discuss slide number 2. The history provided was 35 years old male presented with complaint of lymph node swelling. This was the slide given. Here we can see a non-caseating granuloma which is formed by epithelioid cells and some scattered lymphocytes, and here we can see a foreign body type of giant cells. Along with we can see few lymphocytes which are spread around the granuloma. So the diagnosis made is sarcoidosis. Definition: sarcoidosis is a multisystem disease of unknown etiology characterized by non-caseating granuloma in many tissues and organs. Epidemiology: sarcoidosis occurs throughout the world affecting both genders and all races and age groups. Etiology: the etiology of sarcoidosis remains unknown. Several lines of evidence suggest that it is a disease of disordered immune regulation in genetically predisposed persons exposed to certain environmental agents. Pathogenesis: several immunologic abnormalities in sarcoidosis suggest that development of a cell mediated response to an unidentified antigen. The process is driven by CD4 plus helper T cells. These abnormalities include interstitial accumulation of CD4 plus helper T cells, oligoclonal expansion of T cell subsets as determined by analysis of T cell receptor rearrangement, increase in T cell derived Th1 cytokines such as interleukin 2 and interferon gamma, resulting in T cell expansion and macrophage activation, respectively. Increase in several cytokines in the local environment like interleukin 8, tumor necrosis factor, macrophage, inflammatory protein 1 alpha, that favor recruitment of additional T cells and monocytes and contribute to the formation of granulomas. Polyclonal hypergammaglobulinemia, another manifestation of T cell dysregulation. The role of genetic factors is suggested by familial and racial clustering of cases and association with certain human leukocyte antigen genotypes like class 1 HLA-A1 and HLA-B8. These are some common locations for the lesions in sarcoidosis. As we can see here, these are uvea, skin, hilar lymph nodes which are most commonly affected, lungs, uh, liver, spleen. Other lymph nodes are also can also get affected. The lesions are predominantly seen in lymph nodes and throughout the lung parenchyma. Clinical features: if the lymph node is affected, the nodes are characteristically painless and have a firm rubbery texture. Unlike in tuberculosis, the lymph nodes in sarcoidosis are non-mated, that is non-adherent, and do not ulcerate. Coming to the microscopy. Microscopically, the following features are present. First, the diagnostic feature in sarcoidosis of any organ or tissue is the non-caseating sarcoid granuloma composed of epithelioid cells, Langhans and foreign body giant cell, and surrounded periphery by fibroblast. Typically, granulomas of sarcoidosis are naked, that is, they are either devoid of peripheral rim of lymphocytes or there is paucity of lymphocytes. In late stage, the granuloma is either enclosed by hyalinized fibrous tissue or is replaced by hyalinized fibrous mass. The giant cells in sarcoid granulomas contain certain cytoplasmic inclusions as follows. First, asteroid bodies. Asteroid bodies are eosinophilic and satellite shaped structures. Second, Schaumann bodies. Schaumann bodies or conchoid bodies which are concentric laminations of calcium and of iron salts complexed with proteins. This is a photomicrograph where we can see a lymph node which is having normal lymphocyte aggregation. In between we can see the granulomas which are formed by aggregates of epithelioid cells, fibroblasts, and very few lymphocytes. These granulomas are non-caseating. There is no caseous necrosis seen in the center of the granuloma. Schaumann body. As we can see here, this is a Schaumann body which is a basophilic laminated round inclusions in the giant cell. Asteroid body. A small asteroid body inside the Langerhans cell can be seen. Usually these are eosinophilic bodies. Keim's test. It is a useful intradermal diagnostic test. The antigen prepared from the involved lymph node or spleen is injected intradermally. In a positive test, nodular lesion appears in 3 to 6 weeks at an inoculation site, which on microscopic examination shows presence of caseating granulomas. The diagnosis of sarcoidosis is usually a diagnosis of exclusion. So, the rule out the differential diagnosis is very important. These are the few granulomatous lesions which should be ruled out: tuberculosis, leprosy, fungal infection, foreign body granuloma. For tuberculosis, the special stain of for acid fast bacilli, that is Zn staining, Ziel-Nielsen staining, when done, it shows positivity if it is tuberculosis. For leprosy, fight for echo test done for lepra bacilli gives positive test if it is of leprosy. For fungal infection, fungal stains like PAS and GMS will be positive. And for foreign body granuloma, there will be history of foreign bodies like sutures and other materials. After ruling out all those, if none of the above are present, then the diagnosis of sarcoidosis is given. Thank you.